Thank you for the invitation again, and sorry about getting stuck coming from Harvard here and the change of schedule. But I decided just to do something different to give you more little bit of a case-based presentation and how more the hands-on practically move through a patient and sleep issues, and just talk a little bit of a couple of newer things. So we'd like to make sure that you are aware of the sleep disturbances are treatable, and the importance of obtaining information about sleep problems can help you a lot in management these patients, and just get more detail about what is specifically in sleep, because a lot of the things can be easily addressed, and then apply those strategies to improve their sleep that will improve your pain management. So I will start with this case. It's a patient that I saw as an initial visit, was referred from the pain clinic, 54-year-old woman with multiple medical comorbidities, chronic hip pain, severe osteoarthritis, low back pain, 3 back surgeries, and it was a narcotics dose about 1,200. When I asked her in the sleep clinic what was her sleep schedule, and this is kind of the part, well, we want to know exactly, say, well, patients will come to clinic and will say, well, I never sleep, or I sleep all day, and then you actually start going through the details, and you see that a lot of the times their perception of I only sleep today is actually, when you count the times that they're sleeping, including naps, is more like a reasonable time, 7-8 hours, or the opposite way. So she goes to bed at 9, takes about 20 minutes to fall asleep, which is perfectly normal. And then she gets up around 2 in the morning. She does multiple things at that time, at 2 in the morning until 4 a.m., may watch TV, do chores or anything. And at 4 is when she got in her schedule that she was okay for her to take her pain meds. And then she feels that she dozes on and off until 6:30 in the morning when she gets off of bed, but she does not think that most of the time she's sleeping that time. She wakes up in that period of time that she's sleeping 3 times to go to the bathroom. Sometimes she wakes up because of outside noises, her pain, and some days it's worse, her own snoring, nightmares or night sweats. She does take a nap 5 days a week at least, or every day of the week, usually between noon and 4, and it's usually at least an hour or 2 long. And very similar schedule weekdays and weekends. So when you summarize that, she's like sleeping in bouts of 1 or 2 hours at the most, because that period of sleep between 9 and 2, she goes to the bathroom 3 times. And if you count all those fragments, maybe the total sleep time will be between 4 to 7 hours. And that is clearly not sufficient. She does have most of the sleep out at night, and has the nap more or less early afternoon, which is what your normal circadian rhythm will do. So that will be the most typical times for being asleep. She feels that she can only sleep on her right side due to severe pain on the hip. She was told she snored and she had pauses in her breathing, not aware of waking up choking or gasping. The vast majority of patients are never aware of choking or gasping or shortness of breath. They need a witness, and if they live by themselves, the typical thing is that they will not know. She does wake up frequently with a dry mouth, which is very common for mouth breathers or people that snore. She does have a history of sleep talking several times a week. You do want to know if they're sleepwalkers, because those patients can get injured when they're sleepwalking, and you want to make sure that you avoid benzodiazepines that increase your chances of having parasomnias and sleepwalking in those patients. She does have nightmares that occur 2 or 4 times a week, most of the time related to a motor vehicle accident she was involved a couple of years before. And those, when she had those nightmares, she tended to remain awake because it kind of remind her of the accident. She does not have a formal diagnosis of PTSD or anything like that. In regards of restless legs, she denies any symptoms typical of restless legs, so no circadian component, but she has pain on her legs all the time. And it's not unusual that patients on that in huge doses of opioids will not have problems with restless legs, and when you start tapering down, then you start having more symptoms, because the opioids are a good treatment for restless legs as well. Her Epworth sleepiness scale is 15 out of 24, which is in the sleepiness range, of course. Anything over 9 or 10 is considered sleepy. The reason why she was sent to the sleep center is because at some visit she mentioned that she did have an evaluation for a sleep apnea that was done 6 years before. She was told she had sleep apnea, and she recalls having a CPAP that she was given for her to use at home. She tried to use it. She had no follow-up. She take the mask off during the night, and she was never able to keep it all night long. And she recalls that the few nights that she was able to keep it longer, she feel much better but they're still not getting enough sleep. So what's the diagnosis? And she has multiple things, which is typical for patients with chronic pain. She has poor sleep hygiene. She doesn't have very regular hours. She's waking up in the middle of the night, watching TV, and doing chores around the house. And so that is very, very common because they get into this vicious circle of doing something and they just start going down. She has insufficient sleep because it sounds like a lot of the night she only gets 4 hours and at the most 7 hours per night. She has excessive daytime sleepiness. She has insomnia, and she doesn't complain of sleep onset insomnia. She falls asleep in 20 minutes, which is normal, although her complaint was she had problems with everything in her sleep, but 20 minutes is normal. She does have sleep maintenance insomnia, waking up every hour and a half, in part to go to the bathroom, in part for pain or for other reasons. And then she gets up sometimes at 3 or 4 in the morning, and she stays up the rest of the night. She could have problems secondary to primary sleep disorder. She did have the history of sleep apnea, could be obstructive or could be central given the high doses of opioids. She also had sleep disorders due to medical conditions, which pain is the most obvious one that she acknowledged. She also has some insomnia due to environmental causes or noises or other things in the house. She does have parasomnia. She is sleep talking and had this nightmares. She does not carry the formal PTSD diagnosis, and that was not evaluated in the past. She did have a positive thing that helps when you're retraining these patients into more normal schedule, that she has some preserved circadian rhythm, which is a great help because if you have some preserved internal drive to allow you to fall asleep during the regular sleep hours and to be awake during the regular wake hours, you're already moving in the right direction. So the documentation of those hours of sleep, not just how many in total, but at what time those happen, are very important. And also because you want to adjust the timing of the medications according to those hours of your internal clock to be more effective. So we did a sleep study that showed severe obstructive sleep apnea. She had an AHI, an apnea-hypopnea index of 72.1 events an hour. So she was waking up more frequently than once a minute. There was no, the patient slept in the right lateral position the entire night, which is what she says she does. And a few patients with chronic pain are very limited in the amount of movements that they have and may not be unusual. The majority of patients normally will switch positions throughout the night. There was no REM sleep as well. When you look at the types of events, she had 61 central apneas, 5 mixed apneas, 18 obstructive apneas, clearly obstructive, and the other ones were hypopneas. And the way we score events is like anything that is a respiratory depression abnormality for at least 10 seconds could be scored as a respiratory event. And then if it is over 90% of those 10 seconds, basically a flat line, you don't get any air, is an apnea. And if you have that decrease in the breathing, but it's associated with at least a 3 or 4% oxygen desaturation from the baseline, it's an hypopnea. And mixes when it's half central, half obstructive. So, and the ones that I did not mention there are like the other thing that you will see in the reports are the respiratory-related arousals. The ones that are the 10-second events, you see the decrease in the breathing, but you don't. That is not followed by a 3 or 4% oxygen desaturation. We usually seen in the younger and healthy patients, but they still cause sleep fragmentation, are followed by an arousal. So usually when you have severe apneas and hypopneas, you don't have as many RERAs because you don't have enough 10 seconds events in a minute to put those events. So this was done as a split night study. So the first half of the night was to document the severity of sleep apnea. The second half of the night was as a CPAP titration. And we started with an auto-PAP to see if that will help her. And it was ineffective, which is an auto-PAP is very effective in patients that have plain obstructive sleep apnea, but the algorithm that the CPAP unit has is not very good at adjusting for centrals, so distinguishing centrals. The 402 hypopneas doesn't mean that they're central obstructed, so that's when you have more trouble for the internal algorithm detecting and acting on it. If the machine detects a central, the algorithm tells them not to go up because higher pressures can cause more central apneas. If the machine detects an obstructive event, it will try to go up faster on the pressure. So sometimes the algorithm gets stuck and is not responding the correct way. So then we try an ASV, an adaptive servo ventilation, which is a CPAP machine that instead of having an algorithm to tell you to go up and down with central obstructives, is set to maintain a tidal volume. So adjust the breathing according to what you need. And it's very effective, much more effective in patients that have central apneas due to opioids, because it's able to give you more pressures and maintain the amount of breathing that you have and adjust the breathing so you maintain saturations. So this is an example of what the sleep study shows, and in the top portion you can see that there is what we call the hypnogram, and the top line is the wake. The majority of sleep stages go between 1 and 2. In the bottom, the last graph, green bars, is what CPAP pressures we're using. As you can see, the first half of the night didn't use any CPAP pressure, which is the baseline portion of the study, which is when the sleep is more fragmented. And then we started adjusting pressures, that's line in the bottom that goes up, to try to modify the parameters to make it more effective. As you can see, as we're increasing those pressures, the sleep architecture improves, and she has REM sleep and more consolidated sleep stages towards the last pressures that we recommended. The second bar shows the number of events, and you can see that the first half of the night has a large number of events, and as the pressures go up and we get to the right settings, those pressures decrease. And she didn't have any limb movements, which is the third green line, and the oximetry remained in the high, in the 90s, which is not unusual in patients that have central apneas because they still have a preserved chemoreceptor drive. So to prevent having severe desaturations, they keep waking up. So, and the patient, as you say, she slept on the right all night. So that's kind of what a picture of these studies look like in one page. So then she came back to clinic, and she said the ASV was very effective in improving her well-being, her quality of life. She felt much more refreshed. She feels significantly better. She feels like her mind has cleared. Her Epworth went from 15 to 8, which is in the normal range. And she used the ASV every night for approximately 2.5 months by the time I saw her. She has no problem with the pressures, which is some. But she did have some problem with the mask, and she used a small nasal mask. She wanted a small nasal mask, but she was opening her mouth, so we recommended a chin strap to maintain her mouth closed. But she was feeling uncomfortable, and she said she would like to try a full face mask. The vast majority of patients have problems with the interface with the mask at the beginning of the treatment. Only patients in very high pressures will have problem with the pressure. And it's not unusual, I tell my patients, that at the beginning, even though it's counterintuitive, you may need a bigger mask because when you have sleep apnea, you've been gasping, in her case, 72 times an hour. So you tend to open your mouth versus doing the normal thing, which is breathing through your nose through the night. And once you get retrained that you don't need to gasp anymore, you can move into a smaller mask. And then all these machines have a memory card that give you information. The patient was compliant with the use of the equipment every day with the exception of one. So she used it for those 2.5 months every night. The average daily use was 7 hours and 15 minutes. The machine will record when they're using, what time of the day, how many hours on average, and will record what pressures you're using, if there is leak, and if there are residual events. So the algorithm counts how many events are there, and she was a residual AHI of 0.4 events an hour, which is great compared to she started at 72. She did have a leak through the majority of the days, and that was in agreement with what the patient reported, that she said she sometimes will open her mouth. So everything was consistent with what the patient was saying, and she was doing significantly better. I didn't see her for a while, but the next follow-up, she continued to be managed in the pain clinic. She had a hip surgery that was the main source of her pain. And now she was on a decreased dose of med 570, which was great when she started over 1200. And in some strange situation, she lost her ASV unit, her CPAP unit. And so she came back because she wanted to get the ASV again, because that was what had helped significantly with her quality of life. So given the fact that she was on a much lower dose of opioids, we said, well, let's do another titration, because you may not need an ASV machine if the central apneas are improved. So we did a CPAP titration, and she was fine using a CPAP of 10. They were not excessive central apneas. She maintained the saturations over 94%, and she did fine in that. So at that dose of opioids, the central apnea seems to have to be gone. Because of insurance rules, some insurance will not pay for a second unit unless you used yours for 5 to 8 years. So they say, we're not paying for another unit. And ASV is a large amount of money. It could be several $1,000s, a very sophisticated machine. It has a backup rate, and it's like an external ventilator, basically. But she purchased CPAP on her own. A regular CPAP is only a couple of $100s, and you can buy refurbished on the internet for $65, so it's not a big investment. So if anybody has a smartphone of your patients, can afford a CPAP. So she bought her own unit, and she started using it again and saying that she was feeling better. She continued to decrease the dose of narcotics, and I always, when I see patients, try to document exactly at what time they're taking the medications to see if there is a correlation with some side effects or sleepiness or alertness or interfering with insomnia or things like that. So she kept more or less a regular schedule. She continued taking the medications at 7 shortly after she, like an hour after she woke up, which sometimes patients get stuck in this schedule of how they interpret that medication should be taken, and nobody actually goes with them on the exact timing. But she wakes up at 6 every day, so she waits until 7, and the medication starts kicking in until 7:30 or something. So she had this hour and a half of being awake in higher levels of pain that she was not addressing. And sometimes just a matter of adjusting the timing of the medications helps a lot in the management. And she take an additional Norco and at those times, and she was saving those medications. It was taking 2 additional pills through the night when she wakes up with pain, instead of having a set schedule at 4 in the morning as before. And at some point after I saw her, I mentioned the PTSD. I guess she was started on processing for those nightmares at a very high dose, 8 milligrams, and she said she has no nightmares, and she continued to decrease that dose, and she was at 5 milligrams when I saw her back. So when I saw her the following visit, they downloaded the machine. She had used it the vast majority of the nights, again, 29 out of 30. Over 90% of the days, the average use was 5 hours and 11 minutes, which is less than she was using it before, of over 7 hours. She was using and this is kind of information that the machine can give you. She was using it over 4 hours for 70% of the nights, and she only had minimal leak. The pressure was set at 10. The residual AHI was 29 when I saw her, which is significantly higher than what I expected. But then when I look at individual downloads, there were some days there was an increased number of central apneas. For example, at 4:30, they were in a cluster, and then that night she had a central apnea index of 14, but other nights it was only 2.7. And then we wonder if that extra doses that she was taking in the middle of the night were triggering these episodes of central apneas. And She continued, and I asked her to keep a log of the days she was taking medication in the middle of the night. The last time I saw her was a year later. She continued to feel well, satisfied with the machine. She has no problems. Her sleepiness was increased a little bit since the time before. She was continuing to wake up at night due to pain, but feeling and going to the bathroom occasionally. Very rare nightmares, and overall doing much better, and she was off the processing. She was now able to do much more physically, and now she actually was not feeling that overwhelming tiredness at night, and she is staying up sometimes doing things, which ended up being disrupting her schedule through the day. So our 30-day compliance report show an average use of 6 hours and 40 minutes, but some days you will use it for 10 hours and for almost 11 hours, and some days only an hour and a half. So the percent of days with over 4 hours was the majority, 86%. So there was a much more greater variability on a night-to-night basis, and that was behaviorally induced. She had a residual AHI of 11, and looking at the download, it was a huge variation on a night-to-night basis with this 0.7 to 22. And that she clearly correlated with her logs of when she was taking the narcotics. So by that time, she was already, it's just a correlation with the pain clinic note. She was down on a med dose of 300, and she has less pain. She feels that the medications was allowed her load the medication thinking more clearly, and it was noted that she was using the CPAP nightly. And it's interesting because a lot of times we see notes from the specialist or the primary care where the issues on sleep are completely different than what they report in clinic. And I always like to have other versions of what's happening. And so this is always helpful. So this is what the report of a CPAP looks like, and just for FYI, you can all get that. You just have to request the DME company, the durable medical equipment, the company that is providing her the equipment to give you one of those, and you can actually see yourself. So we usually ask the patients to bring the memory card, and we have the software, but a lot of patients just, we ask the DME companies to give us the information. So the first graph tells you on average how many hours you're using per day. The graph on the other side is basically plotting the times that they've been using it on according to the time of the day. And ideally, you just want a one solid green bar always. Whenever you go to bed at 9, if you go to bed at 9, waking up at 4, that should be the only green bar. As you can see, it's all over the place and with gaps and awakenings, which correlates with what now she is doing due to that she's feeling better, and it's not similar to what she was doing before. And when you look at the specific download, the third bar shows the amount of events. And one of the graphs shows, the one that is almost flat, the darker blue, is the obstructive apneas, which is very, very low. And the one that it goes up in peaks is the number of central apneas. And you can see that some days she had 0 central apneas, not at all. Some days very little, and some days very high. And those clearly correlated with her as-needed opioid dose during the night. This is what you see when you get on a night-to-night basis, and the graph on the left shows you the top line is what pressure she is. She's in a steady pressure of 10. The one in the middle shows you dots that correspond with each one of the events that the machine detects, obstructive central thoracopneas. And the one in the bar just shows you if there is a leak or not. And as you can see, the one in the left side has a very low number of events. The one in the right, you can see there's a clear cluster of events in the second half of the night, and that was the nights that she was taking the additional, I think it was Norco that she was taking or something like that for pain. And those ones she had an AHI instead of a 2 of 20s or something. So we went through that and tried to talk with her about how this will affect her sleep and her fragment her sleep even more. So that was probably in a year interval. So we went through the sleep hygiene. She was doing better with general guidelines, but now she was having a lot of behavioral problems with the sleep hygiene because she was able to do things and she wanted to get up and she will stay up sometimes until 1 in the morning doing things, and she was feeling better. Her sleepiness was better. The central and obstructive apnea were significantly better. The sleep disorder due to pain was clearly better because her pain levels were also much better. Their insomnia due to environmental causes was better. She was not waking up or having to have a low threshold to wake up that every noise will wake her up. The parasomnias improved. She was not having any episodes of sleep talking, which is very common with patients with untreated sleep apnea. They will wake up and have these multiple fragmentations and sleep and have more sleep talking. The nightmares were resolved, and she was no longer in medication for that. The insomnia seemed to be switched to now a behavioral-induced insomnia. The circadian rhythm that before tended to be great now was significantly worse. And the insufficient sleep was also worse because at least because she was so sleepy, she will have a few more hours of sleep. And so the question is, well, what do we do now? How much we keep going? So we try to emphasize the importance of those things. And sometimes it's hard with the patients that are doing better explain, well, if you don't address all those issues, it's going to eventually have a consequence. So one of the big things that I wanted to mention about why do we want to treat, we know how to treat insomnia. We emphasize about circadian rhythms because, and I usually explain to the patients, your body is physiologically determined by all the clocks to do certain things at certain times of the day. And when you're sleeping, you're lowering your blood pressure, tuning up your immune system, consolidating memories. If you one day you're sleeping at the time you're awake, you may be sleeping, but you're not doing all the other biological functions. So your sleep is not as efficient. And that's kind of a way that patients tend to understand better what possible consequences of not having an internal circadian rhythm, a steady circadian rhythm. The insufficient sleep has been debated for a long, long time, and there are all these papers in the field, and it's been an interesting question. How much time do you need to sleep? And everybody has a different answer because it's a very personable thing. But there's been a joint consensus. It was just published, and they review all the literature, and it was performed by the American Academy of Sleep Medicine and the Sleep Research Society. And they came up with guidelines of what will be sufficient sleep, so at least you can provide the patients with this information. So the consensus statement says that adults should sleep at least 7 or more hours per night on a regular basis to promote optimal sleep. Sleeping less than 7 hours is associated with adverse health outcomes, including weight gain, obesity, diabetes, hypertension, heart disease, stroke, depression, and increased risk of death. And sleeping less than 6 hours is also associated with impaired immune function, increased pain, impaired performance, increased errors, and greater risk of accidents. So this consensus review all this literature, and they felt that there was enough evidence for all those issues to be well documented. And there was no agreement for what happens when you sleep more than 9 hours. And the issue is that there is this normal distribution in where some people will sleep 7 to 8, some people sleep less or 9. But in the group that are over 9 hours, there's a large proportion of patients that have undiagnosed sleep disorders, and they may have undiagnosed sleep apnea, they may have depression, they may have multiple things. So the agreement was not as strong in over 9 hours, and they say that people concerned they're sleeping too little, too little or too much should consult their provider. And so I just, the idea is that if you're not sleeping enough, you're accumulating this sleep debt, which some patients may pay with sleepiness, although if you don't sleep an entire day, you cannot spend the entire day following day sleeping. So you're paying in a different coin, which is hypertension, increased pain, memory problems. And that's another easy way to explain to the patients why you want to get them involved in one, they should care about their sleep. And I think I showed this graph before that we don't have a lot of evidence of what is normal or not, but even 7 hours, when you do evaluations of your ability to perform and keep vigilance, the graph on top, the orange one, shows when you sleep 9 hours. And the other graphs show when you're sleeping less hours, 7 hours, 5 hours, and 3 hours. And see how your ability to maintain vigilance decreases over the week. But if you spend the weekend recovery in 2 or 3 days in where you can sleep as much as 9 hours, even when you sleep 7 hours, you don't get back to the baseline levels. So maybe the 7 hours was on the short side, but that's what the agreement is. It should be at least 7 hours. So I have 1 more minute. I just wanted to mention another paper, and it was done in a randomized trial, the bidirectional relationship between sleep and pain. And we usually just think, well, it goes both ways. And this study actually was based on 2 items from the PHQ-9, looking at sleep disturbance, trouble falling asleep, staying asleep, or sleeping too much, and fatigue, feeling tired or having little energy. And those are the 2 questions that were rated for sleep. And when you correlated that with the sleeps, the changes in the sleep complaints at 3 months significantly predicted changes in pain at 12 months. So those patients that did better with their sleep at 3 months, they improved their pain at a year after. And the changes in pain predicted less changes in pain. So it may be that the relationship between how sleep affects pain has more weight than how pain can affect sleep. And which is an interesting thought because it's not being evaluated in regards of quantitative, how much one thing can affect the other. And changes in depression and anxiety did not predict changes in either way. So I thought it was an interesting thing. Then maybe affecting sleep may have a bigger influence in pain than what we have been so far able to say, well, treat your pain and your sleep will get better on its own. It may not be what happens. So just closing slide. Sleep disturbances are common, are very treatable, and addressing sleep issues can improve pain management. And
well, we're just 1 second away, and thank you so much. I have to tell you that there's a lot to the sleep medicine stuff, and those of us who are so old that we never learned anything about sleep are really behind the 8 ball. I'm not sure how I can get up to speed. Maybe the younger people can, but anyway, it's a very informative, and certainly you're pointing out the important connection between sleep and pain, and that's we all. I'll channel Dave Tabin in saying that his point is the first thing he addresses with many of the pain patients is try to get them sleeping better. So we're all, I think, on board with the idea we.
Yeah, but I think that the part of this is the point is that there's multiple tools that you can use now to improve sleep in patients, and it's not just it's a matter of where to channel them or who to ask for help in that regard.
Okay, we are going to have to stop. Deborah Dobbs had a point, but I think that we're out of time now. So
read latent jumps, though.
Latent jumps. Thank you for a nice presentation. I did not fall asleep. Okay. All right. Well, so signing off from UWTelePain. We'll see you next week.